Good afternoon and welcome to another episode of Evergreen Talks with Evergreen Family Medicine in Roseburg, Oregon. I'm Brian Prowitz, your host, and today we have Dr. John Powell who will be joining us for his Evergreen Talk on frontline experiences and the search for more inclusive pandemic solutions. Dr. John is going to take it for the next little while. We're going to have questions and answers toward the end of this conversation. So if you do have comments, you can leave them in the chat and we will get to the comments that we have from folks as we wind down today's Evergreen Talk. But Evergreen Talks are every second Thursday of the month at 4 o'clock. Evergreen Talks is a monthly Facebook Live event where the physicians, providers, and specialists of Evergreen Family Medicine present topics that matter to you. For more information about this conversation and more about Evergreen Family Medicine, visit evergreenfamilymedicine.com for more information. And like you may be doing right now, you can follow us on Facebook, YouTube, Instagram, and Twitter. All right, Dr. John, thanks for joining us today. The floor is yours.
Thank you, Brian. Appreciate that. I've been asked to talk about our clinical experience during this pandemic. But I'm sensitive to the fact that there are a lot of open wounds in this community and a lot of strong feelings. Our perspectives will always be shaped by our experiences. Those of you who have lost loved ones or have survived severe COVID yourselves will certainly have a different perspective about this virus than, say, a single working mother who lost her job and has 3 school-age children. And this is understandable. Physicians are no different. An ICU or an emergency department physician who has experienced the worst of this disease, their experience will be different than, say, an office-based pediatrician or a psychologist who deals with the fallout from the lockdowns and school closures. These are all valid perspectives. These are all important experiences, and they understandably shape one's opinion. I'm no different. I've had intense experiences with this disease. We've diagnosed and treated over 4,000 people with COVID. We've treated severe COVID in all settings, including the urgent care, the hospital, and we followed our patients in the ICU. I've seen patients after their discharge from the hospital and helped manage their prolonged symptoms and at times treated them in the context of workers' compensation claims. Unfortunately, I have seen the full impact of this disease and our response to it. I do believe the intensity and the breadth of my experience gives me some standing to comment and share my perspective with you today. It's true that medical data and practice experience will always introduce personal bias. Medical science embraces different opinions about data and practice experience. But that's not to say that these perspectives are not vigorously discussed and debated. This is what I always enjoyed about medical science. Your opinion can and should change depending upon how the data changes and how those experiences place the data into proper context. The process can be messy and wrong sometimes, but the goal is always to arrive at the best answer. Others will have a different opinion than I do today, and that's okay. We're going to go to the next slide. Today, I'm going to talk to you about Evergreen's experience to this pandemic and during this pandemic. I'm going to focus my attention on the focused protection approach because I think it's been so mischaracterized. But as a part of that discussion, I need to introduce some basic immunity considerations. And then I'm going to venture into the difficult subject of mandates and passports and try to put that into context of data and public health considerations. Okay, can we go to the next slide, please? At the beginning of this pandemic, we viewed this crisis as our World Series, our moment to be relevant. We understood that other diseases and health needs do not just disappear if a new pathogen enters our community. So the goal was always to provide access. I believe our efforts are represented by the numbers on this slide. Since this slide was made at the end of November, we've administered over 15,000 vaccines. We've infused well over 1,000 doses of monoclonal antibodies, and we've diagnosed and evaluated and treated over 4,000 patients within our urgent care and hospital who had COVID-19. As our understanding of this virus evolved, so did our management. It became apparent to those of us who provided hospital care that we needed to try to bend this disease severity curve as early and as much as possible if we were going to have a positive impact on important outcomes like hospitalization and death. So instead of following guidelines only based upon where the patient was located, we tried to treat patients in the context and phase of their disease, their age, their comorbidities, and our understanding of the viral pathophysiology as it evolved. Based on our empiric experience, we think that we made a positive impact. But physicians like numbers to support statements like this. So hopefully our next slide will serve that purpose. This is a busy slide, but it's meant to depict the intensity of our pandemic experience and our efforts to bend the disease severity curve and prevent hospitalizations and death. We did not always win, but we always tried. And I think this made a difference. We implemented monoclonal antibody therapy in February of 2021, and we utilized various treatment protocols. This data comes directly from our Evergreen Family Medicine Clinic. This is not a study. We understand there's many confounding factors in these observations. However, the numbers are meant to support our experience. We know the stories behind these numbers. I want to draw your attention to the intensity of our experience during the Delta surge of 2021. Our urgent care volumes nearly doubled as compared to our experience in 2020 during the same months. Generally, we would expect our hospital activity to track our urgent care volumes, but our hospital activity actually did not increase proportionally. In fact, the hospital activity per urgent care visit decreased between 36 and 55% during the months of the Delta surge as compared to 2020. And in August of 2021, a very busy month for our hospital and our state during the Delta surge, Evergreen had an increase of 53% of hospitalizations during that month as compared to the previous month, or previous year rather. But during that same month, Oregon's hospital census increased over 300%. During a crisis, we did not want to exclude any treatment tools that might reduce the risk of hospitalization or death. We used home supplementary oxygen, monoclonal antibodies, fluids, steroids, antiplatelet therapies, and sometimes blood thinners when they were appropriate. And yes, we used repurposed FDA-approved medication that had shown evidence of benefit and safety in real-time randomized controlled studies outside the United States, as well as meta-analysis research. In all treatment modalities, we understood our critical role in providing informed consent. This next slide is directly from the Oregon Health Authority and supports my comments about Oregon hospital census during the Delta phase. It displays the trends of cases, hospitalizations, and death during the duration of the pandemic through the end of December 2021. If you look at the middle diagram in orange during the months of the Delta surge, in 2021, it's depicted by the orange peak to the right. And if you compare it to the same months in 2020, you will see that the peak hospital census increased over 300%. They were between 100 and 200 patients in the beds in 2020 during this time frame versus over 700 patients in August of 2021. Once again, during our busiest month in August of 2021, our hospitalizations increased just over 50%. Go to the next slide, please. This slide is intended to provide a bigger picture. It's so easy to lose perspective during a crisis. During this pandemic, there have been so much emphasis on daily case numbers or deaths for a single disease. One might think that this was the only problem physicians were dealing with. It's unfortunate that during this time frame of January 2020 through December 21st, there were 311 Douglas County residents who died from or with COVID-19. Every year in Douglas County, between 1,500 and 1,700 people die in our county of just over 112,000 people. Some may recall that I said in the spring of 2020, at the end of the year, heart disease and cancer would still be the leading causes of death. So let's look at that data. This slide comes directly from the Oregon Health Authority Vital Statistics, detailing the leading causes of death for 2020. As you can see, cancer and heart disease were once again the leading causes of death. COVID ranked number 10, just 5 more deaths than suicide. There's no question that COVID will move up this list in 2021. But it's hard to say how this is going to move up because the CDC is still trying to work out how to differentiate between those who died with as opposed to those who died from COVID. Let's go to the next slide, please. As many of you may be aware, since the spring of 2020, I have been an advocate for a focused protection approach. Before 2020, this approach would not have garnered any type of controversy. It was a pretty standard approach for public health. Unfortunately, this approach was consistently misrepresented by many. In October of 2020, physicians and scientists from Harvard, Stanford, and Oxford universities collaborated and published the Great Barrington Declaration. They were advocating for a focused protection approach. Over 15,000 public health scientists and 45,000 physicians from around the world have signed this document. There was an immediate effort to misrepresent and discredit this approach. It was astonishing to see. There were no formal debates, just personal attacks and disparaging remarks from those who wanted to control the conversation. Unfortunately, we now know from emails that were obtained from the Freedom of Information Act that the directors of the NIH and National Institute of Allergy and Infectious Disease coordinated with one another and the media to discredit these mainstream medical scientists as being fringe. I've never been so disappointed and embarrassed by institutional medicine's response to these thoughtful scientists. This is not how medicine's culture of free inquiry and debate is supposed to function. So I'm going to talk a little bit about the public health approach that was censored as it relates to a focused protection approach. A focused protection approach requires us to have some basic understandings. First, what is the pathogen and how is it transmitted? As you may recall that initially there were reports out of China that suggested that there was no human-to-human transmission. This quickly transitioned to this is a droplet spread transmission. But then a scientist from Virginia Tech and others suggested that many at the CDC believed that COVID was aerosolized by February of 2020. This was eventually confirmed by the CDC in the fall of 2020. Why is this important? An aerosolized spread would suggest different mitigation measures, especially if the virus had already penetrated the population in all four corners of the country, as was the case in March of 2020. We need to understand how lethal the virus is so we can respond in a measured way. We understood in March of 2020 that this virus had a significant age severity differential. At the time, I was looking at South Korea data in March, and there were over 3,000 infections confirmed in those under the age of 30, and there were 0 deaths. And the case fatality rate, not the infection fatality rate, was 0.2% under the age of 60. However, our approach was to treat the disease as equally lethal to everyone, regardless of age or comorbid conditions. There are 2 fundamental measurements in epidemiology that need to be understood during a disease outbreak: incidence and prevalence. The incidence of a disease is how many new cases there are, and prevalence is how many have had the disease. If we acknowledge the existence of natural immunity, which we should, and tracked it like a vaccination, it would suggest the population that is at risk for severe disease. Prevalence is also necessary to determine the infection fatality rate. Case fatality rates will always overestimate the fatality risk in a population, especially early in the pandemic when we don't have a lot of testing available and we're only testing those that require hospitalization. We did not aggressively try to answer these important questions early in the pandemic. Instead, we implemented some of the most extreme and restrictive measures. We locked people in their homes without symptoms. We discriminated between essential and non-essential businesses. We never had this degree of contact tracing for an aerosolized respiratory virus that was already widespread. We shut down schools based upon modeling forecasts for our population of Oregon. The decision seemed to be stay the course until we have a vaccine. But before 2020, the mumps vaccine was deployed the fastest in history, and it still took 4 years to do this in a safe manner. I certainly did not expect a successful vaccine using a novel messenger RNA platform to be offered to the public within 9 months. But I was wrong about that. Next slide. Sometimes it's easier to explain what a focused protection approach isn't. It's not letting it rip, silly, irresponsible, nonsense, or impossible. These are not scientific terms, but they were used by scientists and physicians in leadership positions to squelch discussion. The focused protection approach is not testing elite asymptomatic college and professional athletes 3 to 5 times a week. A focused protection approach is not elevating modeling over actual data and viral pathophysiology. It's not utilizing modeling to determine whether schools should be able to open or close. Do you remember in the late summer of 2020 when we were trying to obtain just 10 or 11 cases per 100,000 residents for 3 consecutive weeks, hoping that our disease positivity rate would be less than 5% so we could open school on time? When this was announced, I knew if we stuck with this strategy, school wasn't going to open on time. Many came into our urgent care who needed to be tested for COVID, but they didn't want to mess up their child's chance to return to school. But we still failed to meet these modeling targets, and so did everyone else in Oregon. So we were criticized for not doing enough to keep the numbers down. We just weren't trying hard enough. The modelers changed the case number goals from 10 to 50, then 150, then 200. And then the authorities said, never mind, you decide. And we did. And we were finally able to retain some local control of our destiny. It felt good. Our kids were allowed to return to in-person learning. Civilized countries always put their children first. A children's education and critical life experiences should not be sacrificed because adults are afraid of their own safety. A focused protection approach is understanding the pathophysiology of the virus, the age severity differential, the overall infection fatality rates. Then people should make an informed choice based upon their own circumstances and their own risk tolerance and their own immunity. A focused approach seeks to protect the vulnerable by using rapid testing in the environments where they reside and to test symptomatic people and use proven effective mitigation measures. But we have to be honest that mitigation measures are never going to be 100%. For those who are at low risk for complications from the virus, they should be allowed to live their lives normally. And by doing so, they will acquire immunity to reduce the transition to the more vulnerable. Basically, this was Sweden's approach. Irresponsible, many said, but let's look at the numbers. This is the daily death curves throughout the course of the pandemic for Sweden. And in the next slide, I'll show you the United States. You notice that Sweden has 2 distinct death peaks. Unfortunately, they have very large nursing homes in Stockholm. And at the beginning of the pandemic, the virus penetrated these locations and they lost a lot of people. Sweden's public health officials refreshingly acknowledged their mistakes and they self-corrected. However, they did not shut down schools for 1.8 million children. There was not a single death recorded in these children who attended schools, and there was not evidence of increased viral transmission to teachers beyond the rest of the population. Kids were advised to stay home if they were sick and go to school if they were well. They did not mandate masks. They were encouraged to participate in normal physical activities, both inside and out. You may notice that the Delta wave in the summer and fall of 2021 is non-existent. They were averaging less than half the deaths per day compared to Oregon during the Delta surge, despite having over twice the number in their population. Oregon may have delayed infections, but at a very high cost. Next slide, please. Meanwhile, in the United States, we've experienced more waves despite high levels of vaccination and mitigation measures. In terms of deaths per million people, the United States has more than 1,000 more deaths per million as compared to Sweden. The US has averaged over 2,500 dead per million, whereas Sweden has averaged a little over 1,500 deaths per million. Next slide. So this is a critical part of my talk today. It is curious as to why recovered immunity is not acknowledged. It is important to differentiate between a sterilizing immunity that eliminates the transmission of the virus. That would be viruses like measles, mumps, and polio. Those are DNA viruses as compared to, say, coronavirus and influenza, which are RNA viruses. The difference is that DNA viruses have a more stable structure. They don't mutate as often, whereas RNA viruses are single-stranded, and a lot more errors can occur in the transcription process. And so even though that the CDC was recently unable to document a single case of viral transmission after recovered immunity, we obviously know what happens. With the Omicron variant, we know what happens both with the vaccinated and the naturally recovered immunity. But there are some questions that need to be answered. Too often these questions are not encouraged. For instance, how does natural immunity compare in terms of severity of illness and hospitalization and death to vaccine-acquired immunity? These are important questions, and they're knowable. There's now over 140 studies that show recovered immunity is broad, robust, and durable for COVID. This research is also consistent with our clinic's experience, and it's exactly what we would expect. We can only hope a vaccine can be as good as recovered natural immunity. Next slide. Yeah, we're on. Okay, this is the right slide. People knew about acquired immunity since 430 BC. This is not 430 years before COVID. This is before Christ. During the Peloponnesian Wars, there was a plague that killed many people. And the historian Thucydides noticed that those who had recovered from the disease could take care of the sick without becoming reinfected themselves. He had discovered natural immunity. Next slide. There are two basic or general types of immunity. There's innate immunity, which includes physical barriers like skin and mucosal secretions, things like natural killer cells, natural antibodies such as IgM and IgG. They are less specific, and they have lower affinity antibodies as compared to adaptive immunity, but it's quite good. And you were all born with this innate immunity. It's probably why early in the pandemic, when there were viral loads that were much less, kids were able to get infected with the COVID and never show symptoms. Their innate immunity was taking care of the virus. So it could be sterilizing. But adults have it as well, but it just tends to wane as we grow older. Adaptive immunity or acquired immunity is much more specific, and it has the capability of memory. So if you see the bug again, it recognizes that specific strain and can respond to it. But it's oftentimes misunderstood as just antibodies. There's a cellular immunity, which includes memory B cells and memory T cells. And when the pathogen invades the body again, the B cells can reproduce those same antibodies long after they have faded. T cells also have this memory, and they can assist the antibodies to take care of the virus, but also identify cells that are infected with the virus and eliminate those. We would expect antibodies to diminish over time because if they did not decrease over time, our blood would be as thick as sludge. Think about how many infections you've had over the course of your lifetime. There's a complex dance between our innate immune system and our adaptive immunity. I've enjoyed immersing myself in the complex and technical fields of immunology, vaccine science, virology, evolutionary viral biology during this pandemic. I'm not an immunologist, but I am a doctor, and I know how to find immunologists, and I know how to read their research, and I love to listen to their debates. Many scientists have made predictions about the pandemic and how it would evolve. Many were wrong, but some have been correct. The correct ideas that have been shown should gain credibility, especially if their predictions are consistent with clinical experience. This is how empiric science is supposed to work. I suppose you could call it the trust but verify approach to scientific discovery. I found that there's this complex dance between the innate and adaptive immune system that's not fully understood, but it needs to be respected. A little more humility about the nuances involved might be prudent before implementing and mandating public policy around this complex process. We seem to be implementing the current policy like a sledgehammer, and there's plenty of evidence of the existence of a robust and broad natural immunity as an important driver to protect individuals during this pandemic. This study was interesting because it showed both B cell and T cell immunity was broad and durable. But there have been other studies that have shown cross immunity with other coronaviruses, including common cold coronaviruses, and they could help neutralize even SARS-1 and MERS. And at Oregon Health Sciences University, where I attended medical school, researchers demonstrated B memory cells in the bone marrow nearly a year after natural infection. This study was published at the end of 2020. This was evidence of immune memory that should have influenced policy, but it didn't. There's also some evidence of real-world immunity on the next slide. I think that many people have heard about the Israeli study that demonstrated how robust recovered immunity was as compared to vaccination for both breakthrough infection and hospitalization. But there was also another large clinic or study from the Cleveland Clinic that showed no evidence of reinfection over a 5-month period of time. I recognize that there are some who will tell us that natural immunity plus vaccination will represent a superimmune status if you're measuring higher levels of IgG levels, antibodies. However, I'm less impressed with endpoints that measure antibodies or PCR positivity as compared to more meaningful endpoints, such as reduced hospitalization and death. It's unclear how recalling antibodies to a wild-type virus that is no longer in circulation may help against recent variants with a highly mutated spike protein. I am convinced that discounting a broader, more relevant recovered immunity is not the right public policy. Immunity is important. It doesn't matter how you get it. We should be allowed to ask these types of questions. Mandates. At the beginning of this pandemic, I indicated that there was a scientific, economic, and political consideration to this pandemic. I had hoped that the hierarchy of decision-making would be prioritized in that order. What I did not foresee was the degree that medical science itself would be politicized, and it wasn't always by politicians. My concern is that the scientific process has been derailed by neglecting its principles of open inquiry and debate that I was so fortunate to experience early in my career. Censorship, personal attacks, and a lack of transparency is a dangerous place to be. I do not agree with mandates or passports. But I think it's best for mandates to be discussed in the context of public health data and ethics, and not politics. This slide suggests some questions that we generally ask before implementing public health interventions. At the beginning of the pandemic, many were told that the virus was going to be eliminated. I never thought this was going to be the case. The virus is not going to just go away. If we stayed home or wore masks, we might delay it for a while, but ultimately, respiratory viruses do what they do when they're aerosolized. They make their way through the population. In the spring of 2020, I suggested that COVID-19 would join the other 4 coronaviruses that we commonly measure in the hospital using a respiratory PCR panel. COVID is a highly mutable RNA coronavirus. By the time this virus was found in the United States, every corner of this country was impacted. Our goal should have been to mitigate the total harm during this pandemic. But by only focusing on the virus, we were missing the big picture. We needed to be honest that the virus could not be eradicated, and cases would continue to occur. Do you ever recall hearing an official discussion about the impact of each proposed policy by those who proposed it? Do you recall any in-depth debate from opposing viewpoints from scientists as to why small businesses were deemed non-essential, but larger stores could remain open? Do you think that the policy was implemented fairly and that there was equal sacrifice? And more importantly, was there any consideration that the policy itself may have unintentional harms that could be worse than the virus for some? With this last question, I'm thinking specifically about what we've done to our youngest generations. Oh, the greater good. What about the greater good? Dr. Brandt was an important historical figure, and we can talk about him later if we have time. I think many of the current policies and mandates reflect this value, and I acknowledge many physicians would agree with this statement. But who gets to decide, and whose greater good? What infection fatality rate is high enough to take away one's bodily autonomy? Or ask for your papers to go to a public football game or travel? I disagree with this statement on so many levels. But first, during a crisis, during periods of panic, drastic decisions need to be avoided unless there's a very strong case that can be made that the interventions will reduce total harm to a population. There should be an open debate and discussion about alternatives. This was not done well, just the opposite. Scientific and open discussion was censored. Based on the data, the current approach of mandates will not eradicate the virus or save lives, in my opinion. A change in policy is needed, and the next slide from the Oregon Health Authority illustrates my point. This slide takes us through January 1st, 2022. You can see that the percentage of breakthrough COVID-19 cases on the right-hand side of the slide has surpassed 40%. And there's a little bit of delay when adding new data. Our current experience in the urgent care is well over 50% are involved breakthrough infections in fully vaccinated and boosted individuals. Next slide. This slide is looking at the number of deaths, breakthrough deaths in the state of Oregon. And you can see in October of 2021, we had 29% of the COVID-related deaths were in fully vaccinated individuals. This slide in particular will be delayed because determining the cause of death and entering the data is usually a month to 6 weeks behind, it seems. Next slide, please. In November of 2021, I found this article in The Lancet. It indicated that stigmatizing the unvaccinated was not justified, in part because of what I just showed you in regards to breakthrough infections. We should not continue to call this the pandemic of the unvaccinated. Nevertheless, there are individuals around the world of maltreatment of its citizens based upon one's perceived immunity status, and the state not acknowledging recovered immunity. Does this not seem like we're labeling people as clean and unclean? If you read your history, you will understand the danger of this characterization. Dostoevsky understood suffering and human behavior. I ask myself sometimes, how did we come to this place? I love what I do, and it's a privilege to be a physician. I've always viewed my practice as mainstream and evidence-based, but also personalized to the individual in front of me. So it has been unpleasant to find myself in the center of controversy. It is true that I have sometimes provided a message apart from what the government and its agencies prefer to be heard. I do not enjoy being a messenger with a different narrative. But as I observed the collateral harm to our youth go unrecognized or dismissed as temporary harm, I was alarmed. As I witnessed the skyrocketing mental health and addiction issues in our community as unemployment spiked, my concern increased. As I saw small businesses close and newly unemployed called non-essential, while others safely worked from home, I saw unequal sacrifice. As I witnessed our efforts to provide early treatment criticized or labeled as unsafe by those who have never treated COVID patients, I was surprised. As I have seen natural immunity ignored and people lose their employment who have served the needs of their community, I knew that we lost our way. And when I saw my noble profession that I respect politicized and important medical information suppressed, I could not remain silent. Well, thank you for listening today. And Brian, I think I may have missed a slide. We need to go back to that. We can talk about it. Thank you.
Thank you, Dr. Powell. So, was this about where you were when you thought that?
Yeah, it's okay. Okay. Maybe we can leave it to questions and it'll come up.
Okay. All right. I'm gonna do a couple of adjustments here. You had said that you wanted to talk about a doctor that you had mentioned midway through, and that maybe we could talk about him again. Dr. Brandt?
Oh.
I thought I'd give you the opportunity to expand on that just a little bit, since you said, you kind of indicated in a way that you might want to come back to.
Okay. Dr. Brandt was a very respected surgeon in the 1930s and 1940s. He married an Olympic swimmer and who was quite a celebrity. They were asked to go to a gala in Germany in Germany, and unfortunately, one of the generals in front of him ran off the road and had a compound fracture. And so he personally took over the care of this general and mended his leg and saw him through his illness. But unfortunately, as fate would have it, he was noticed. And he was noticed, unfortunately, by Adolf Hitler, because he said, "I need one of those surgeons." So he was asked to take over the medical system for Germany. And during the war on the Eastern Front, Germany and Russia, carpet bombing was common then. And so hospitals in the metropolitan areas were demolished. But psychiatric hospitals oftentimes were out in the woodlands and they were preserved. But they were running out of space for these wounded soldiers. And so the doctor said, we need a place to treat these folks. And we're going to go ahead and have the psychiatric patients go elsewhere. And so he told Hitler, I need this to happen. And so he gave his authorization. During that period of time, the soldiers did better because they had these facilities. Unfortunately, the psychiatric patients didn't do well. In fact, so much so they were starving, and the psychiatrist said, this is inhumane. It would be better if they weren't alive. That quote that I included came from that context. He said, for the good of the many, basically, we're going to let these folks die. So there's always a story. There's somebody always making a decision. And unfortunately, we know the rest of that story. Dr. Brandt was hung in 1948 in the Nuremberg trial.
That is a chilling story indeed. We have a few questions here, and the first one is, what is the purpose of contact tracing, isolation, and quarantine, and how was this intervention used in the past?
Brian, this can be an incredibly important tool in public health, and we use it still for sexually transmitted diseases. We try to contain the disease. The problem with using it in this scenario, it's meant to prevent the spread of the disease. And with COVID, it had already spread when it was discovered in the United States. And it's as an aerosolized virus. Right now, the last CDC estimate was nearly 150 million people have had COVID. I think it's much higher than that. But how do you contact, trace, and quarantine people at this juncture? You can't at this point. So it's meant for cases like syphilis or gonorrhea, those kinds of cases where we can limit the spread, identify those individuals, treat them so we stop the spread.
A common question that people are asking right now, if one is recovered from a COVID infection and natural immunity is real, why is there a recommendation to still get vaccinated? Also, the possibility of how are people who've been vaccinated and possibly even boosted still getting sick? Kind of fit together a little bit.
Yeah. Well, so the thought is, and as I mentioned, I think the study I forgot to mention was more about is the Israeli study and the Cleveland Clinic study. I touched on those. But the CDC also showed some studies. One was from Kentucky. There were some others. And one of the most important measurements that they identified is that after natural infection, if you boost someone, you have much, much higher antibody levels. So the question I would have is that a good thing? Is that a good thing? I don't know. But what I do know is that it's not the most important thing, because we already showed you that everybody will have their antibody levels drop over time. And the cellular memory immunity is much more important. And we have ways to measure that now. There is emergency use authorization for a T cell test. It's called T-Detect. And by the way, it's a 99.8% specificity. It's been shown to have a 95% sensitivity, meaning you can pick it up at 95% of the time at 6 months after an infection. And it's also 95% sensitive at 10 months after infection. So this T cell immunity is critical, but they're not measuring that. They're measuring IgG or antibodies. And these always fall off for the reasons that I mentioned. Otherwise, we'd have sludge. So for me, it's not so important to tell me that I have higher antibodies, especially if I'm not sure if they're relevant antibodies. So as time goes on, our variants have mutated a great deal. In fact, the Omicron variant, which has well over 50 mutations, and I think 37 of those mutations have occurred in the very narrow receptor binding domain where the vaccines have targeted. Some people have suggested it's mutated so much it really should be called COVID-21. But the point is, if you have an antibody that doesn't, it's not relevant, are they helpful? Do they get in the way? How do they interact with your innate immune system? We should be able to ask those questions. And people are asking those questions. They're just not being heard. And they're not getting honest responses, in my view.
Another question, can you expand your discussion about when public officials make decisions for the greater good or made decisions for the greater good?
So this is a tough one because we have used this before. I mean, obviously smallpox. And these comparisons are commonly made. Well, we require vaccinations for school, for instance, for measles, mumps, polio. We eradicated smallpox. The difference is these are DNA viruses. They don't mutate like RNA viruses. And so after an infection, by the way, if you went to school, you had the measles, you aren't required to get a shot for the measles. You have immunity. So one of the things about this is, number one, when you are talking about the greater good, can you eradicate the disease or not? And I think people are coming to terms with the fact that this is going to be with us. We're going to have to live with COVID-19, COVID-21. It'll mutate just like influenza does. But if we have some basic immunity, it becomes what we'll call endemic in a population. It pops up from time to time in certain areas, but you never eradicate it. And it was my opinion that in the spring of 2020, this is where we were going to be, because we couldn't contain it. We didn't get to contain the virus. So to me, if you're going to ask the question, should you mandate something for the greater good, it should accomplish the purpose that you say you want to accomplish. And eradicating the virus is not one of them. And you never ask someone else to assume risk on your behalf. So if you feel like you need the vaccine to improve your immunity, by all means, I think vaccination is extremely important. I'm a family doctor, after all. I mean, I spent my whole career advocating vaccines. This is different. We're asking people to take a vaccine and discount. Let me just give you an example. I saw a college kid, fully vaccinated, last vaccine 2 months ago. He got the Omicron variant. He wasn't very sick. He had a stuffy nose. But Oregon, he had to go back to Oregon. He said, I have to get a booster to go ahead and go back to classes. I don't have a good scientific response to that student, why he needs a booster. He had the most relevant booster with his Omicron variant. We need to stop this insanity of mandating vaccines. This is really harmful. That kid, if he took a vaccine, he gains no benefit. But we know as a 20-year-old kid, he assumes risk for myocarditis. It may be small, but for no purpose, that's not an ethical decision.
Those are the main questions that we have received. There are many, many comments and questions, as we expected, mostly on Facebook. And I'm just wondering if is there another topic or two that you hear a lot about that you want to add your expertise to?
Well, let me just make a couple of comments because about the Omicron variant, because we're seeing a lot of cases of Omicron, obviously. We had to, because of the mutation that occurred with this virus, the Regeneron is no longer effective. And so at the end of December, we changed to Citrobactam. And it's been very difficult to get monoclonal antibodies. We were successful early in February. We're one of the first adopters here. But lately, we ran out today. We have no Citrobactam. And that's really unfortunate. I think there are some inefficiencies that need to be corrected, because people, for the vulnerable, not most people with Omicron, kids are getting sicker with Omicron. There's no question about that. I think that we know from the South African variants, when they did the PCR testing, it's kind of a proxy for viral loads. So when you look at the Delta variant, the average PCR amplification was around 27. But for the Omicron variant, it was 23. That would suggest there's higher viral load. And with higher viral loads, the thought is that it might overcome the kids' innate immunity and they get sick. And as a result, we're seeing sick kids. But other folks that have some form of immunity, either recovered immunity or vaccinated immunity, they're generally doing okay, and they tend to be less sick. But there are exceptions. And we feel that having a relevant monoclonal antibody treated very early in the course of the disease process can make a difference. And so I hope that we'll get our supply. We've asked always a week in advance, and we are not getting it now. I don't think there's any facility in Douglas County that has it right now.
Okay. Well, what I would ask or recommend to you is that you come back to the Facebook page and maybe answer some of the questions that are here, because there are many. I'm afraid of opening that can and getting into a Q&A with you. It could go on for a long time, but there are some very good questions in the queue that you might be the perfect person to answer from the point of view that you've described today. So lots and lots of comments thanking you for your approach to this and for this information. So I know that this will be one of, if not the most popular Evergreen talk that we've had as far as interest and the number of comments. And it's certainly, as you mentioned, it has certainly come at a certain price, I think. But sharing your experience has been, I think, very helpful and important. So thank you for your time.
Thank you, Brian. Appreciate it.
Evergreen Talks will be live on Facebook and YouTube on the second Thursday of the month at 4 o'clock. And this is where Evergreen's physicians, providers, and specialists present topics that matter to you. And you can see more about this. You can read the Powell's blogs as well at evergreenfamilymedicine.com for more information. And we are live on Facebook and YouTube. You can follow Evergreen on Facebook, YouTube, Instagram, and Twitter. All right, Dr. Powell, thank you very much. I hope you have a good afternoon.
Thank you, Brian.
And we'll see you again soon on another Evergreen Talks.
Thank you.